Hello, I am Bridget Gant. I will be presenting my therapeutic modality presentation on the effectiveness of art therapy in mental health. My next slide is titled Art Therapy, Unmasking PTSD. It includes 3 images of masks created by veterans who were participants in an art therapy program. An introduction to art therapy. Art therapy is the use of expressive art creation as a form of psychotherapy for people experiencing trauma or illness, seeking personal development, or struggling to deal with the day-to-day act of living. Art therapy, through the act of creating art and thinking about the process, people are able to develop skills that increase cognitive ability, awareness of self and others, and help them cope with the distressing symptoms or limitations imposed by disability or disease. Art therapy is a methodical use of means through drawing, painting, collage, and sculpturing to shape and express feelings, thoughts, and memories. Art therapy is distinguished from other forms of treatment through active performing and experiencing with art materials. Art therapy enables the processing of traumatic experiences by assessing and integrating traumatic memories by communicating and documenting images of traumatic memories. Art therapy aim is to elicit processes of change, development, and acceptance using art in a methodical way in the treatment of psychosocial problems and mental disorders. The history of art therapy. Art is known as an early form of communication which dates back to the cave art of Paleolithic age. Therapeutic rituals using visual arts can be found in ancient cultures from hundreds of years ago, such as Navajo sand paintings and African sculpture. Art therapy is an interdisciplinary mix of visual art and psychology. The use of therapeutic art was defined and developed into a distinct discipline. In the early 1940s, in the United Kingdom, Adrian Hill was generally known as the first person to use the term art therapy. He discovered the therapeutic quality of art making while recovering from an illness in 1938. Mr. Hill recorded his ideas in 1945 in his book called Art versus Illness. His contributions became a milestone for the acceptance and practice of what we know today as art therapy. About the same time Mr. Hill coined the term art therapy, in the United States, Margaret Namberg, a psychologist, called by many the mother of art therapy, began to publish clinical cases, and in 1943 she gave a name to the new field by calling her work dynamically oriented art therapy. Ms. Namberg based her work on the idea of using art to release the unconscious by encouraging free association. Art therapy has been recognized as beneficial and effective treatment for both mental and physical conditions, such as traumatic brain injury, schizophrenia, sexual abuse, breast cancer, depression, dementia, post-traumatic stress disorder, as well as a method of enhancing communication and bolstering self-esteem. In the early 20th century, psychiatrists became interested in artwork created by their patients suffering from mental illness, and by mid-century, Hospitals, clinics, and rehabilitation centers increasingly began to include art therapy programs along with traditional talk therapies. Case study presentation. Mr. J is a 49-year-old male who is an active duty service member in the United States Armed Forces Army Division for the past 28 years. Prior to deployment, he reported living a normal and stable life, which included a healthy marriage of 15 years and raising his 3 sons. Mr. J denied any previous or current medical history of any physical or mental illnesses. The only surgical history he reported was to repair a leg wound injury. His developmental history was reported as being normal. He grew up with both parents in a loving home and had good academic achievement in school and college. Mr. J reported having a successful military career for over 2 decades, until a series of incidents occurred during a wartime deployment about 8 years ago. He reported suffering a moderate traumatic brain injury when a mortar barrage hit his base with multiple rounds impacting near him. While taking cover, Mr. J reported he sustained a shrapnel injury to his left leg, loss of consciousness, and post-traumatic amnesia for about 30 to 45 minutes. He further reported several other traumatic incidents during that deployment. However, Mr. J recalled the most traumatic experience for him was witnessing the death of his comrade and fellow commanding officer to an improvised explosive device. He stated, "That should have been me because he took my place that day. I don't deserve to be alive." Following his return home from a 2-year deployment, Mr. J reported feelings of guilt, isolation, anger, and self-condemnation about his friend's death. In an attempt to abate the intrusive thoughts about the traumatic deployment events, he isolated himself from family and friends and inundated himself with work. He also began drinking 1 to 2 glasses of wine per day to help him relax and sleep. During a 6-month follow-up visit with his primary care physician, he reported increased feelings of anger and anxiety, feeling depressed, lack of interest in his favorite activities and libido, a lack of motivation, increased frequency of intrusive thoughts about the death of his friend, and flashbacks, which he described as a bloody face of an unknown identity in the same bunker area of his injury. Mr. J angrily repeated several times, "It's my fault he's dead. It should have been me." He reported he thought the anxiety and depression, as well as the flashbacks, would have subsided by now. However, he declined treatment at this time. He stated, "There's nothing wrong with me. I just need to get some rest. I'll be fine." 2 years later, Mr. J stated he is experiencing increased inability to focus on his work and non-work related tasks, and he has feelings of guilt, racing thoughts, easily startled, persistent flashbacks of the unidentified bloody face, and isolation. Additionally, he reported unusual alertness and an increased level of energy despite sleeping 2 to 4 hours per night. He is also drinking 3 to 4 glasses of hard liquor daily. Several co-workers reported witnessing over the years a decline in Mr. J's work, isolation, a display of unusual behavior and bizarre comments about an overactive processor in his head, and making gestures attempting to turn a dial in the front of his head to try and slow the processor down. Due to his declining quality of work and uncharacteristic behaviors and comments, the Chief of Staff recommended an immediate mental health evaluation and potential treatment. The DSM-5 diagnostic criteria was used to determine Mr. J's diagnosis. Under Criterion A, he witnessed a traumatic death of a co-worker during wartime deployment. He sustained a traumatic brain injury and other traumatic bodily injuries. Under Criterion B, re-experiencing recurrent intrusive thoughts and memories of his friend's tragic death. He had flashbacks of an unknown bloody face. Under Criterion C, he avoided distressing thoughts or feelings about the traumatic events through isolation and excessive work. Under Criterion D, he constantly blamed himself for the death of his coworker. He lacked interest in his favorite activities and libido, and he lacked motivation. He had persistent feelings of guilt and anger. Under Criterion E, he had hypervigilance with increased alertness. He had difficulty focusing on work or other tasks. He had ongoing complaints of insomnia. Under Criterion F, the duration of his symptoms have lasted greater than 1 month. For Criterion G, the disturbance has caused a significant impairment in his social and occupational functioning. And Criteria H, the disturbance is not attributable to his physiological effects of a substance such as medication or alcohol or another medical condition. Based on Mr. J's severe symptomology, he meets the DSM-5 criteria for PTSD, and he has a mild traumatic brain injury. He was enrolled in a comprehensive 4-week intensive outpatient program. His treatment regimen included sertraline 50 milligrams per day and 12 cognitive behavioral therapy sessions 5 days per week. A review of Mr. J's MRI and MEG images revealed hyperintensities in the left occipital lobe, vision center, and a significant relative reduction in normal waveforms on the left frontotemporal regions, respectively. These significant reductions were most prominent in Broca's area, related to the verbal production of speech, and the right parietal region that is believed to be involved in creation of visual art showed a significantly better rest waveform pattern. Given the severity of Mr. J's PTSD and diagnostic test results, the interdisciplinary team determined that he would benefit from a form of nonverbal therapy such as art therapy and cognitive behavioral therapy. Mr. J reluctantly agreed to participate in 2 trial art therapy sessions, which were described to him as a therapeutic process to aid in emotional regulation and increase his satisfaction with life. He was scheduled for Mass Making Art Therapy program and CBT. The mask-making exercise objectives are to reduce immediate symptoms and address the underlying problems that may perpetuate PTSD symptoms, provide a safe environment through authentic expression without being threatened, provide an opportunity for externalization of visual and tactile memories, promote and enable development of positive emotions and reconciling guilt and trauma, Identify the difference between what is being communicated with others versus what he or she is actually feeling. After completing the scheduled art therapy sessions, the therapist and client will have an exit interview to discuss and compare their progress from beginning to completion. If the client did not meet all of their therapy goals, additional sessions in conjunction with cognitive behavioral therapy will be recommended. The impact of art therapy. Mr. J successfully completed 12 therapeutic art therapy sessions despite his initial resistance and suspicions, which may have been associated with social stigmas surrounding treatment for PTSD. He initially responded to the art therapy sessions in isolation. However, using reenactment of the traumatic memories as well as actual materials such as dirt and shrapnel from the war zone injury helped him work through the incidents that had been haunting him for several years. And he was able to externalize many of the images that were trapped in his mind that created intrusive thoughts. Mr. J was also able to integrate one of his traumatic experiences into creating a series of masks, which led to the initiative to create a mask of the main image that had been haunting him, known as Unknown Bloody Face or UBF. During one of his midpoint sessions, the art therapist offered a potential idea for Mr. J to create a box for the UBF mask to be put away or buried in. He became immediately interested and decided to execute this idea. Mr. J painted the interior of the box yellow to symbolize shedding light on UBF and to express his pursuit for understanding who, what, why he exists. Then he painted the outside of the box gray and collaged it with magazine clippings such as an image of plastic bags blowing in the wind as it represented freedom, yet still attached, and phrases stating frozen in time, which was placed inside the top of the box, finding balance, start fresh, and straight talk. These phrases were placed on the exterior of the box. At the end of his 4-week program, Mr. J stated that although he still has some haunting flashbacks of UBF, they have become less frequent, and he feels content with the closure he has gained during the mask-making process. And he plans to continue individual art therapy in conjunction with CBT for identified visual processing disturbances. In a note written to his art therapist, Mr. J stated, "These art sessions have provided me the ability to gain a more comprehensive understanding of my traumatic memories, actions, and situations that have caused my survivor's guilt, shame, and depression. Initially, I thought I would paint one mask of myself, but as I started, that subconscious piece of my psyche kicked in and I rapidly produced one of my hauntings, UBF. Once the mask was completed and contained in a box, the flashbacks have become an infrequent memory and allows me to view them differently. I am now able to work through my recurring memory of guilt." Evidence-based practice. Campbell, Decker, Kruk, and Deaver 2016, conducted a randomized control study to determine if art therapy in conjunction with cognitive processing therapy, or CPT, was more effective for reducing symptoms of combat PTSD than CPT alone. The authors concluded that both groups achieved clinically significant gains. However, integrating art therapy with CPT improved trauma processing and was one of the most significant contributions of art therapy intervention. Copyton and Lebevity, 2013, conducted a randomized study using an experimental group and a control group to assess the therapeutic effects of group art therapy for patients being treated in a specialized psychotherapy unit for war veterans diagnosed with PTSD. The authors concluded that art therapy does not necessarily develop one's sense of humor as much as it enables a considerable number of war veterans to more freely express humor in their art and verbal communications during art therapy sessions. Palmer, Hill, Lobin, and Murphy, 2017, conducted a cross-sectional design study to explore the acceptability of art therapy as used in treatment for PTSD experienced by veterans. The authors concluded that the findings imply that participants were willing and able to engage in art therapy, and it has implications that provide support for the inclusion of art therapy for treatment programs that target this group. Art Therapy Study Guide. Art therapy is facilitated by a professionally trained and certified art therapist. Art-making activities are used as a therapeutic tool toward the process of healing, clearing the mind, and self-expression. Art therapy is divided into two categories: art as therapy and art psychotherapy, which is a form of expressive therapy which is based on the idea that art is a vehicle for symbolic communication. Art therapy involves a therapeutic relationship between the therapist and the client. It takes place in a safe, non-threatening, and confidential space. The main goal is self-expression. Art supplies are used as tools for self-expression. There is no right or wrong way to create things or use art materials. Focus is on the creative process. Artwork is seen as a reflection or extension of its creator. It is used for communication. In conclusion, art therapy is a unique method of using artwork to explore feelings, reconcile emotional conflicts, foster self-awareness, manage behavior and addictions, develop social skills, improve reality orientation, reduce anxiety, and increase self-esteem. Through the creation of art, veterans can verbalize and resolve traumatic memories and events while developing coping skills and managing stressors. The act of self-expression has additionally been associated with feelings of self-worth and positive emotions. Through the use of art therapy, veterans with PTSD can communicate their experiences in a non-judgmental environment and improve memory fragmentation, avoidance symptom cluster, nonverbal expression, externalization, relaxation, and self-efficacy. Although the available studies provide useful information about the effectiveness of art therapy, however, given the high incidence of PTSD among combat veterans and others, future research is vital. and should include a robust methodology on the effectiveness of art therapy. It should examine which aspects of art therapy are most effective in the treatment of PTSD. It should explore which groups would benefit most in the terms of age, sex, trauma exposure, and symptom profile, and whether military-related PTSD and traumatic brain injury follow similar patterns of symptoms and response to treatment. Art is not what you see, but what you make others see. Edgar Degas. This concludes my therapeutic modality presentation, and I hope you enjoy it. Thank you.